Hello, everyone, and welcome to my MASLD podcast. My name is Whitney Steinmetz. I'm a family nurse practitioner. I practice in Albuquerque, New Mexico with Presbyterian Medical Group. The main point of the chat today is to talk about MASH and MASLD and type 2 diabetes and how do we take current medication and optimize the care in this patient population. So the first thing that I get asked a lot is, why are patients with type 2 diabetes at high risk for getting MASH and advanced fibrosis? Why is that such an important thing that we hear so much at conferences and in the literature and when we're talking with our colleagues? I think it's a combination of a lot of things. It's this confluence of metabolic factors. We have inflammatory factors, insulin resistance that occurs in diabetes, and it increases the risk so significantly. It's like this perfect storm of insulin resistance, lipotoxicity, chronic inflammation, and metabolic stress that has this accelerant type effect on fibrosis in ways that when you have a patient with MASH or MASLD, you want to be looking for diabetes. And when you have a patient with diabetes, you want to be looking for metabolic associated liver disease. So you want to be looking at those two things because you can find them in each other all the time. So the next thing I get asked a lot about is to discuss the effects of standard type 2 diabetes medications, like the different classes, and what's their effect on liver fat, inflammation, and fibrosis, and which are the ones that we consider to be potentially beneficial for MASH. So there's so many classes out there. The first thing I would tell you is if you're not already doing this in your practice in gastroenterology, start taking more ownership of this. I think, our patients are struggling with just the fatigue of so many appointments and everybody's bouncing people around so much in specialty care. And I think what this question is really driving at is when you see these patients in clinic, they're asking for you as the expert to say, what are the ways that we can optimize here, right? What are the ways that we can take what you're doing and make it better? Or how can we make some swaps here? So let's talk about metformin. That's a really common one. So it had some mild reductions in effect on liver fat, mainly due to improving insulin sensitivity, but it has no direct effect on fibrosis and inflammation. It's not specifically approved for MASLD and MASH treatment. So then we have the GLP-1 receptor agonists. These showed significant reductions in liver fat, anti-inflammatory effect, and is showing in preliminary trials that it's reducing progression in fibrosis scores. And we suspect it's probably going to get approved for a MASH-specific indication at the end of 2025. So next we have the SGLT2 inhibitors that showed moderate reduction in hepatic steatosis, improved oxidative stress, and systemic inflammation. Preliminary data in 2025 is showing the potential slowing of fibrosis progression, which is a really great thing. So then we have the dual triple incretin agents, the GIP, GLP-1 agonists. They showed robust reductions in liver fat content and improvement in metabolic markers and had a potential benefit in fibrosis scores with ongoing trials going on in 2025. Then we have the TZDs. So those improve insulin sensitivity in the adipose tissue, muscle, liver, and promote that redistribution of fat from the visceral regions to the subcutaneous stores. Both the ASLD and the EASL or EASL recommend use for fibrosis-confirmed MASH in patients with type 2 diabetes and prediabetes, but really important to know that some of the common side effects here are weight gain, which is often not something we want in this patient population, fluid retention and edema. So be really careful in your patients with heart failure or other reasons why they might be retaining fluid, and the potential fracture risk in our postmenopausal patients. So how should we as APPs approach medication selection for patients with type 2 diabetes when we know they have coexisting MASH, considering both the glycemic parts and also the potential liver benefits and risks? So, one of my primary goals, in addition to thinking about what my patients' wishes are and their preferences, is I'm always trying to minimize my contribution to polypharmacy. I look at these patients' lists all the time and I'm overwhelmed. I'm overwhelmed by the amount of medications they're on, who made changes. Patients don't know what they're really supposed to be taking or why they're taking it. There's a lot of different people. So the medication burden is real for everyone. So with that in mind, I try to think about medications that are going to address the most amount of issues or kind of have a dual target approach. So remembering that diet and lifestyle is the mainstay of therapy here, I want to think about things that are going to improve their glycemic control, offer weight loss, and also have potential hepatic benefits, right? And so the two big classes that I think of are the GLP-1 receptor agonists and the SGLT2 inhibitors, because it also addresses this dual target. So the great thing about those two classes of medications is it has that dual target approach that we're talking about here. So what helps their glycemic control and also has that effect on the liver. And then some of these medications have this additional benefit on their cardiovascular and renal comorbidities, which make them great potential options for patients who, again, have those other comorbidities. So is there any kind of specific diabetes medications that we need to be careful with or use caution or even just generally avoid in patients that have really advanced fibrosis, cirrhosis, decompensated cirrhosis? So keeping in mind advanced fibrosis is F3, F4, cirrhosis being F4, and then thinking about compensated versus decompensated cirrhosis. So, in general, I'd be careful with metformin in your patients with advanced cirrhosis due to that lactic acidosis risk. Sulfonylureas, especially glyburide and glymeparide, are hepatically metabolized. So I'd be careful in patients with Child-Pugh class B and C cirrhosis with that drug class. And in general, I really avoid pioglitazone, especially in patients with decompensated cirrhosis due to that risk of fluid retention and edema, especially if they have concomitant issues with heart failure, because we see so much anasarca and fluid overload. And there's other medications available that wouldn't contribute as much to that. So that's not a drug class that I would use. Thank you so much for tuning in. If you have any other questions, please feel free to reach out. And thank you so much for your time.